Okay, so good morning. So this is Manos Brilakis, and next to me is
Dr. Subhash Banerjee.
And we're from VA North Texas Healthcare System and the University of Texas Southwestern Medical School. Today we'll have a webcast on treating elective and high-risk PCI patients with Impella 2.5. This is a webcast that's supported by Abiomed and is run through the Dallas VHS Corporation. And the goal of this is to be a very interactive session. So please, any questions you have or any thoughts that come up, please say them on the phone, or you can text us through the WebEx interface. And we look forward to your participation.
Very good. So Manas, begin with the didactic part, and then I'll take on the case. And again, feel free to jump in with questions and comments.
Great. So what is the options for mechanical circulatory support during PCI? And this is something that all of us who do interventions are dealing with, but the goals are to improve perfusion of various organs, especially the heart, and unload the ventricle. And there are two broad categories. There's the circulatory support devices and the ventricular assist devices. And those can be divided into ECMO, which is not available to many centers for PCI at least, or to formal cardiopulmonary bypass. But what we use in the cath lab is the percutaneous ventricular assist devices, and specifically the balloon pump, the Impella, and the tandem heart. And these are the ones that we'll focus on today's webcast. So a brief description. On A is the Impella, and the Impella device has an inlet area. Essentially, blood is inserted from the left ventricle, and then it's pumped all the way into the aorta. We also have the tandem heart, which is a continuous flow pump, absorbing blood from the left atrium and outputting it into a peripheral artery with a 15 or higher French sheath. And last, we have the balloon pump that essentially inflates diastole and increases perfusion of various organs, as well as decreases the output for the heart. So Impella has an inlet area. That's where the blood enters into the device from the left ventricle. It has a pigtail that allows it to be positioned in the left ventricle. And then has a 12 French motor that sucks the blood. Now there is the Impella CP, or cardiac power, that has a 14 French motor that can give up to 3.5 liters of volume. And what the Impella can do is to reduce the LV end diastolic volume. It also can decrease the LV end diastolic pressure. It also increases the mean aortic pressure and flow. Now, there are different varieties of Impella device. There's the Impella 2.5 and the CP that we use in the cardiac cath lab. But also there are larger devices, the Impella 5.0 and the Impella LD, which are 21 French, and these are placed in through surgical incision. So for the cath lab, the options are the 2.5 and the Impella MP, again 12 French versus 14 French femoral arterial sheath. And this is a brief illustration of how the Impella works. So again, this is done through arterial access, usually femoral, but it can also be done through axillary or other routes in case that there is no good access in the femoral. And then the device is inserted retrograde into the left ventricle. There's a marker that's supposed to be in the aortic valve level. And once again, the inflow of blood comes from the ventricle, and then it's pumped out all the way into the aorta, improving the perfusion of various organs and as well decreasing the preload of the heart. The Impella is controlled through the Impella controller, which checks the position of the device and to have a nice arterial waveform. However, what can happen sometimes is the device can be sucked into the ventricle, especially with the larger devices, and then can get a ventricular signal, which helps you understand your malposition and try to correct the positioning of the device. Now, when should you not use the Impella? So there are specific areas that are contraindicated. One is having severe aortic stenosis or having a mechanical aortic valve. If the patient has aortic regurgitation, that's also a problem. If the patient has a ventricular septal defect, that's not a good option because obviously the deoxygenated blood from the ventricle, the right ventricle, will go into the left ventricle. And in patients with recent MI, it's important to not have left ventricular thrombus to avoid systemic embolization. Severe PAD is a relative contraindication because now Impella can be placed through alternative access routes such as axillary. Usually we do that with support from the vascular surgeons. And the goals are to stabilize perfusion, to balance myocardial perfusion against demand and supply, augment peripheral perfusion, and allow performance of complete revascularization in patients with multivessel coronary disease. Now, when do we use it? And usually it's done in patients who are considered high risk. And high risk is a very broad definition. It has to do with coronary anatomy, with unprotected left main or multivessel disease. It also includes hemodynamic component with reduced ejection fraction, and also includes various patient comorbidities such as presentation with acute coronary syndrome, diabetes, PAD, and other surgeries. So there are many different varieties of patients who are high risk who might potentially benefit from use of hemodynamic support. Now, what is the data? The data behind hemodynamic support. There is an early study called BCIS-1, that's the balloon pump assisted coronary intervention study, done several years ago, published in JAMA 2010, that randomized 301 patients with low ejection fraction and a coronary jeopardy score of more than 8 to either use of balloon pump prophylactically or no use of intra-aortic balloon pump. And what was found in that study, which again is with balloon pump that provides limited support, is that at dismissal from the hospital, the incidence of major advanced cardiac and cerebrovascular events was similar whether balloon pump was used prophylactically or not. However, 12% of the patients in the no balloon pump group did require rescue balloon pump during the procedure. There was numerically lower events in the balloon pump arm. However, they were not statistically significant. However, on long-term follow-up, mortality was actually lower among patients who had intra-aortic balloon pump prophylactically versus those who did not. Now, the second study that has been done with prophylactic elective PCI use of hemodynamic support is the PROTECT-2. That is a study that randomized patients to either balloon pump or Impella 2.5 device. The primary endpoint was the 30 days composite major adverse events, and that was a composite of death, myocardial infarction defined as 3 times higher upper limit of normal of CKMB or troponin, stroke, repeat revasc, cardiac or vascular operation, limb ischemia, renal dysfunction, increase in aortic insufficiency, hypotension, angiographic failure. So there's been many components of this primary endpoint. The study was stopped prematurely. However, what was observed is that amongst enrolled patients, there was significant improvement in ejection fraction as well as New York Heart Association class. There was also significant reduction when a per protocol analysis was done in the incidence of MAEs up to 90 days. And you can see the curves kept on diverging up to 90 days after the procedure. What was also seen is that in patients in whom rotational atherectomy was not done, there was a more pronounced benefit, and part of this was the issue of being more aggressive. When support is there, people were more aggressive, using more frequently rotational atherectomy in patients who were protected versus those who were not. And based on this data, there is the guidelines saying that the class 2B indication for using hemodynamic support during PCI, and the specific wording is that elective insertion of an appropriate hemodynamic support device as an adjunct to PCI may be reasonably in carefully selected high-risk patients. However, as you can see, we're a little behind. This is from 2011, and now it's 4 years later. And this year, the SCAI-ACC expert consensus document was published on use of percutaneous mechanical circulatory support, and this is kind of a summary of their recommendations, which divide patients based on complexity of the PCI as well as the technical challenge of the device, as well as the patient's ejection fraction and hemodynamic instability. If the patient has an anticipated complex PCI and LV dysfunction, then use of hemodynamic support is recommended. In those who have either complex PCI or low EF, then it's recommended as a backup. And those who have a normal EF and non-complex PCI, then it's not recommended. Again, it's an evolving field. There is lots of expert opinion, and something that we need more data, obviously, down the line as things evolve. Now, how about AUC? And many people make this question that we do have a lot of complex procedures being done. Are those procedures indicated? And the reality is that although these are indeed complex procedures, these are the patients that are more likely to have angina. They have severe symptoms usually, and they have low ejection fraction. So in general, they're actually more likely to be appropriate for PCI than those who have simpler disease. So you can see here you have 2 or 3 vessel disease, and you have a lot of symptoms. You're going to be appropriate. Same here. A lot of multivessel disease and high risk for non-invasive stress testing in severe symptoms. This is going to be appropriate. So in general, those procedures in which hemodynamic support is used are going to be more complex, and they're going to be more appropriate than other procedures. And what do you think? That's a common theme that people are being concerned about. What do you think about the use of hemodynamic support and the appropriateness?
I think this is a great slide, and I think though it is a consensus document, however, it does indicate that in patients with low ejection fraction or symptomatic heart failure with complex anatomy or with compelling symptoms of a high level of ischemia demonstrated by non-invasive tests and angina and multivessel disease, I think this is completely appropriate. I think most of us who perform complex interventions in cath labs do see these patients on every day, so this makes it very relevant to practice.
Excellent. And again, complete revascularization is something that's talked about a lot, and this is data from PROTECT 2 showing that in patients who got protected, they were more likely to remain stable when multivessel PCI was performed.
So Manas, let me ask a question and maybe have the audience jump in. So the presence of a support device, a hemodynamic support, and stability of the patient as a result of it may impact the strategy the interventionalist adopts in the cath lab and the choice and selection of devices. I think that was an important point I want to reiterate based upon what you just showed, and also from the PROTECT 2 trial, and also from the completeness of revascularization. Would you agree with that, or?
Exactly. I think you hit the nail on the head. I think the bottom line is that you do a complex procedure, and the patient starts getting unstable, then you're more likely to bail out. You're not going to start doing your complex bifurcation or your complex CTO or anything complex when the patient is not doing well and you're concerned about stability. Then you're going to stop, unless, of course, the patient is in shock and needs to be resuscitated. So I think having the patient completely stable allows you to focus on opening up those more complex lesions and achieving the complete revascularization.
So the following question, I'm just following up with Manas on this and taking to the test, is that these are observations made from studies that were done as part of analysis of PROTECT 2. I'm sure our group and some others have looked at this in a more systematic fashion. Would you be sharing those data today in terms of completeness of revascularization and overall outcomes, both short-term and long-term?
Yeah, absolutely. And we'll see that this is from PROTECT, as you said, that you're showing that the more complete revascularization you have, the less likely you have to major adverse events over the ensuing 90 days. But I will show some other data down the line showing that complete revascularization actually results in better outcomes, less mortality, and less need for repeat revascularization. Another factor to consider, apart from the completeness, is also the hospital stay. In a current era where obviously budgets are very closely monitored, you want to minimize the duration of stay, and actually using support devices was associated in PROTECT 2 with 2 days less in the hospital, with all the benefits both for patients' well-being as well as reducing costs. And this is the idea, the mechanism of why hemodynamic support can be useful in patients. The reason is that in this patient, for example, who has severe heart failure, last patent conduit, class 4, previous bypass, not a surgical candidate, and something goes wrong, then pressure is going to go down very fast. You don't really have much time. Within a minute or so, the patient may have severe hypotension, being collapsed. having a support device can allow sustaining some perfusion while this is happening and allow you time to take corrective action, fix the problem, so the patient can be salvaged. What we want to avoid is the patient ending this spiral, downward spiral of shock,
and then consider Impella,
from which it may be hard to resuscitate.
Makes sense.
What is happening across the nation? This is data from NCDR published last year, and what is actually seen is a tremendous increase in short-term mechanical circulatory support, whereas the use of intra-aortic balloon pump has remained about the same, as well as the use of short-term non-percutaneous mechanical circulatory support. So there's a significant increase, and at the same period of time, what has been observed is a reduction in mortality. Of course, it's hard to be causal here. There are so many factors changing over time, but this is an encouraging trend that with increasing use of circulatory devices, concomitantly there's been a decrease in mortality. And based on FDA indication, there is one device that is currently approved for use in high-risk PCI, and this one is the Impella 2.5. And this is the exact wording from the FDA. So the Impella 2.5 is approved as a temporary, less than 6 hours, ventricular support device, indicated for use during high-risk PCI, performed in elective or urgent hemodynamically stable patients with severe CAD and depressed LVEF, when a heart team, including a cardiac surgeon, has determined that high-risk PCI is the appropriate therapeutic options. And of course, the heart team remains critical for performing high-risk procedures. Some of those patients, many of them may be appropriate for coronary bypass graft surgery, but for those that the heart team deems as preferred for PCI, then use of support can help.
And a very, very important point, I think this must be reiterated, that it is a component of the strategy of revascularization and not an independent standalone recommendation.
And that's a common question, comes up a lot for CTOs, comes up for any kind of complex PCI. Again, this is a tool, and can benefit from different options than other patients may. So this is something to consider for the appropriate patients, but it's not obviously for every patient. And the mechanism of this is that Impella 2.5 may prevent hemodynamic instability resulting from reversible ischemia that can occur during planned temporary coronary occlusions and reduce the peri- and post-procedural adverse events. And we're going to switch now. Subhash is going to present a case which allows us to discuss these things and go over a practical application of the procedure.
Well, thank you. Manas, thank you very much for that review. And if you have any daring questions, and he loves to be challenged, and we will do that all together at the end of this. But however, let me take you and put what Manas has shown in the first part of the presentation to a test. We have chosen a case that will hopefully generate a lot of discussion and a lot of questions, and then you may or may not agree with our strategy. Hopefully it'll be a good demonstration of what we want to project and what we want to share and discuss with our colleagues who are well equipped and trained in cath lab procedures. So this is a patient who who had a significant non-STEMI at an outside hospital. He had multiple risk factors, and he was initially hypotensive, requiring a short duration of presses during his hospital stay at an outside hospital. And subsequently, after initial stabilization, underwent a diagnostic coronary angiogram at the outside hospital, and here is the angiogram. I hope you can see it. The left main looks okay. There is some intermediate disease maybe, but the main focus here is that there is a occlusion and of the medial AD just past the first septal and the first diagonal branch. There's also a flow-limiting lesion, looks like in the circumflex. And there's another view from the RAO side of the occlusion and left-to-left filling of the distal and mid and distal LAD. As you guys can see it cleanly and visualize the circumflex lesion in this view, more LAO, and the lesion is in the mid circumflex, just past the occipital marginal branch. And here is the RCA, which is dominant RCA with the mid and proximal lesion. The mid lesion definitely more severe. So this is the patient. As I said, he required a short duration of pressors and was initially unstable. And the interventionalist, this referring center, tried to perform a crossing of this LAD occlusion with a guide wire alone, and this wasn't successful very much, and required subsequent intra-aortic balloon pump support, with which he was then referred to our center for further management. So this is a very brief description of the patient. So imagine you see him in your hospital in ICU, and you're called in. He had a repeat echo done, demonstrating that his LVEF was severely depressed globally. EF estimated was about 20%. So the first question that we have, and please feel free to jump in and make your comments, and is that what would be the most immediate next steps? The options, of course, here are: number one, refer him for emergent coronary bypass surgery. Number two, consider PCI with intra-aortic balloon pump. Number three, PCI with Impella support, or PCI with tandem heart support, on the expertise that each one of your institutions have. So if there are any takers on what they would do in this situation, would be very, very welcome.
Or maybe it's just going to hang out.
Please try to respond in the next 2 minutes. And if you have any opinions, or if you want to send in your comments to a chat line, we would welcome that too. But what do you want to say?
Yeah, we're going to actually mute the lines because we have a lot of interference on the outside line. So you may not be able to. So if you don't mind, just
chat and the text
send it in the text segment of the device, because we have a lot of interference from other noise. But I think this is a kind of common scenario. You have a patient with reversal disease, and the patient comes in, has low ejection fraction. Now he's stable. He's hemodynamically stable. He does have a balloon pump. They place prophylactically in the other hospital. I think the first thing to do here in a stable patient is talk to a surgeon. He has severe disease, a CTO on the LAD probably, or possibly. I think the first thing is talk to a surgeon and see if he'd be a good candidate.
The only caveat is that the patient was initially unstable. Now he is stabilized, is more stable. But I still believe, I agree with you, that having a thorough heart team discussion and discussing with the surgeon is probably the first thing to do, because there is no real immediate need to jump into a high-risk PCI at this point, and this discussion would be completely appropriate. So that's.
Yeah, I think so. I think the issue here, if the patient was unstable, then you do whatever it takes to stabilize him, emergency PCI, everything. But if the patient is stable, and then you do a PCI without having, discussed with everyone, and then something goes wrong, then you might have a bad outcome, and people may discuss, why didn't you ask them first? So I think it's always a good idea in stable patients, complex anatomy like the one you have here, discuss with the surgeons, and if they don't want to take him, then obviously that makes it much more justifiable.
I think that looking at the angiogram, is it also conceivable, I'm sure this thought has crossed your mind, that is this LAD occlusion more acute or more chronic? Because I think the initial impression that the operator might have had is that this was probably the culprit and may have tried to intervene on it. But looks like from his PCI side, PCI images, that this was probably more complex, and maybe the right was the more acute or the more non-STEMI lesion. Is that correct?
I completely agree. I mean, you don't know if the LAD is acute or chronic. He does have a lot of very good collateral circulation, which makes it more likely to be chronic, but that's not a reliable differentiating factor. So I agree with you. This could be either way, and regardless, acute or chronic, it's already been failed somewhere.
Yes.
So clearly it's not a straightforward lesion. You may need some more work to be offered. We see some comments coming through, and please use the text segment if you don't mind. So I think people are saying that at most centers, the patient would need a surgical consultation to assess for bypass for complete revascularization. Completely agree with that.
I think we agree with that. A heart team discussion is absolutely necessary here. So let's move on, and I think we have generated some discussion here. So the patient, we have a system of discussing these cases with a surgeon through an interdisciplinary conference that we have every Monday, and this was done, of course, more urgently. But and the surgeons at the end decided not to take this case on, and we have just simply listed the reasons that were discussed. And in this case, first, that the patient had received and was loaded with clopidogrel. Number two was that he had a recent high-risk ACS with instability that required pressors and intra-aortic balloon pump, though now the patient was much more stable than before. And finally, that his EF was severely depressed. And I think those were the reasons, and we may disagree or agree with this strategy. However, the heart team decision was to at least attempt and proceed with PCI in this case instead of taking this guy more urgently for coronary bypass surgery. And I'm sure if you have comments based upon your institutional preferences and your set of practice, I think that would be, we would welcome those thoughts and discussions. But we did go through a thorough evaluation with CVTS.
And I think the pretreatment is a common theme that we see in our practice. I don't know if other practices. As you know, the pretreatment is a complex area. The ACCORD study did not show any benefit with procedural pretreatment. Actually, there was more bleeding and no benefit. And depending on population, like for example, in our institution, we don't load people before because we have a high rate of bypass because of the very high complexity of coronary disease. But and some surgeons may be more open to operating on clopidogrel or other P2Y12 inhibitors, but it is a major consideration, and people have had significant bleeding if they go for surgery immediately after P2Y12 administration. But that was an important factor.
I think what you said is absolutely correct, but I think the only caveat would be that this risk might be even more exaggerated with non-clopidogrel P2Y12 inhibitors.
That's right, absolutely.
So that would be a good point. So I think that was the strategy. So we decided to proceed with PCI, and the question would be, the following question is, that would you check, what would you do in terms of Impella support? Would you actually consider a femoral angiogram and make sure that the vascular access, I think the answer obviously is yes. I'll just take the liberty to answer it for you. I do think that was performed, and you can see the femoral angiogram on the left side. As you know, remember the patient had an intra-aortic balloon pump insert from the right side, so the strategy was to remove the intra-aortic balloon pump without giving out the access, replacing it with initially an 8, and if not necessary, then plug the hole with a 9 French sheath, and then proceed with PCI.
And actually, Subhash, if I can say, it's interesting, you know, in the past, for balloon pump at least, we didn't used to take an angiogram because, well, it's a small sheath and everything. But, you know, there's been some cases where people don't do well, they get leg ischemia.
Absolutely.
And now we routinely do an angiogram before placing a balloon pump, which is not uncommon preoperative for left main patients. And you'll be amazed how often we find issues. But of course, for Impella, with a larger sheath, it's even more important.
And there's another factor that in our practice, Manas, I'm sure in many of the other practices, that we routinely try to pre-close these vessels with Impella. So I think it is important that if a pre-closure is being planned, that an femoral angiogram be performed, which is not routinely done with intra-aortic balloon pumps.
And another question that came up is, do we need 2 surgeons to decline these cases before we take these high-risk PCI cases on, as we did with the early TAVR experience? That's another question that came through.
That's a great question. You know, I think this is institutional practice, but generally in our interdisciplinary conferences, we have 1 surgeon generally. But I think there have been situations where we are not able to reach a consensus. We have certainly reached out in those, but it has not been routine practice for us for coronary bypass alone to adopt having 2 surgeons decline the case. And feel free to chime in. And if this is an institutional practice for these high-risk cases, I believe it would be completely appropriate if some institutions do have that practice of having 2 surgeons decline these cases. I think.
Yeah, I think it's perfectly fine. In my mind, it's the logistical issue too, depending on the surgeon. But it's different, I think, than TAVR. I mean, this one is a standard bypass, standard PCI. There's much less controversy. Techniques are mature both ways, both for bypass and for PCI. In my mind, one surgeon says it's not, and I know unless I believe the patient really needs bypass, in which case I would proceed with a second surgeon, very high complexity cases. But otherwise, if the surgeon says no, and we agree that PCI might be the better option, we don't necessarily get a second opinion. There are some lower risk cases in which we believe bypass is a better option, diabetics especially, and then in those cases, yes, I think it's worth getting another opinion.
Very well. Thank you for your comments. And so, skipping forward, you can see we were able to successfully get an Impella into the left ventricle. The balloon pump is still there. As I mentioned, we then removed the balloon pump from the right common femoral access site, preserving the access. The strategy here would be to keep a guide wire in, remove the sheath, try to put in initially an 8. If it doesn't tamponade out the whole, the arteriotomy, then use a 9 French, and you can even use a second intra-aortic balloon pump sheath if that is necessary. So I don't see the use of having both these devices, and this question again has come up before in this particular instance. And we of course had to do a complex PCI, and that was another reason why we needed a large caliber common femoral access sheath and chose not to proceed with this kind of PCI from radial access.
Excellent. And there's a question about any issues putting the Impella in when a balloon pump is in place, and there's no other issues except for going standby on the balloon pump.
Absolutely.
And otherwise, have no issue at all. I think the device goes easily, unless you have severe aortic disease or something unusual. When Impella goes in, there's plenty of space and there's no issue with the balloon pump.
Absolutely. So again, I think we have partially answered this question. What French size guide? I think our belief is to go with maximum support possible in this case. 5 and 6 probably are not great options in this, and I think a femoral access site would be highly preferred in my opinion, and that is why we chose to go with an 8-French system, and we were ready to go with a slightly higher if necessary if the arteriotomy from the intra-aortic balloon pump side would not be adequately tamponaded.
If I can say, I think in my mind, one of the things happening now with the radial approach is that it's a great approach, but makes people uncomfortable with using the large guide catheters. I think when complex interventions like this are being done, in my mind at least, it's actually more secure, more safe to have a big sheath and a big guide catheter, because something goes wrong, then you have much more support. You can deliver things easier. Something goes wrong, you can tamponade things. You can do many more things, bifurcation standing, that it's much harder to do with a smaller guide catheter.
I think the only option might be to use a sheathless guide in some situations of radial, but this would not be an ideal situation for it. So the following slide is adopted from our CTO slide deck, but I think the emphasis here is to go with maximum support. Consider a longer consider femoral access with 45 centimeter sheets, large caliber guide catheters. Prefer to use shortened guides, and of course consider dual injections if the distal vessels are not adequately visualized. We generally prefer a heparin, and of course ready to manage complications and monitor irradiation doses. So here is a recap of the angiogram. We showed you the medial AD occlusion, the proximal the mid-circ disease, and the proximal and mid-right coronary artery disease. And the question here is that which of these lesions would we first tackle addressing this high-risk coronary anatomy in a patient who we have just inserted an Impella device. So again, any chat-based, any typed comments or any audio comments would be highly accepted. And I think, what do you think, Manas? I mean, I think my personal view would be to go first with the RCA. Seems like to be the more technically reasonable thing to do here, and it will provide us some support and some cover when we deal with the circumflex and the LAD, and probably that would be the way. But I think there is no right approach, and we have received some text responses again agreeing with us, so that RCA would be the first choice, and that is exactly what was done. Straightforward GR4 guide engagement and a soft crossing SI wire, which crossed fairly straightforward.
But you go back one step.
Yes, please.
I think you're right, and people are saying, in general, you do use the simpler one, and they're asking what hemodynamic support. And I think the answer in my mind is that it still doesn't change. I mean, the hemodynamic support, in my mind, you want to use it as an insurance policy. You want to actually avoid you needing it. You want to avoid getting in trouble and needing to support you if you can. So even though it's nice to have it, you wish you don't use it. So still, I would first, I prefer to treat the more complex stuff first, and then treat the less complex lesions afterwards.
So the RCA was treated first. In this case, pre-dilated with a balloon after using a soft Asahi wire to cross, and a 3/0 by 38 millimeter DES was used. As you can see in the subsequent lesions, that it seemed that the stent was expanded. I've not shown in the angiogram, but the IVUS shows that there is a significant underexpansion of stent in some areas and requiring post-dilation. The area, as you can see in the midsection indicated, is 5.25. And in the midsection below is much better, and the second area is 7.65 millimeters square. And again, the movie of the IVUS is shown on the right panel. This requires a pre-post dilation with non-compliant balloons to appropriately expand these lesions, and then before completing the diagnostic, the PCI of the right coronary artery. I think that is an important
But if I can say, I think another benefit of having support is you actually feel more confident that you have the time and the energy it takes to expand it. And a common criticism for CTO operators is sometimes we focus too much on getting the wire through and then do a not such good job in getting the best result in expanding the stents. The same applies for any kind of complex PCI, multi-vessel or single vessel. I think the key thing is to take your time, make sure you get the nice big areas, and that minimizes stenosis, minimizes stent thrombosis, gives the patient the best chance for an eventful recovery.
Couldn't agree more, Manas. Couldn't agree more. I think intravascular ultrasound for these cases is a very, very useful addition to optimize PCI. As you can see, not rely just on angiographic result, but also on good lumen size and areas with intravascular ultrasound. So the right coronary artery intervention was completed. The patient so far was doing well. As we have already discussed, our strategy was to go from right to the circumflex and then to the LAD. And we then intervened on the circumflex. Again, use a routine work-through wire to cross the lesion, pre-dilation with an undersized balloon, and then stenting with DES. 2.75 times 28 millimeter DES were used in this situation. And again, our usual strategy is to confirm this with IVUS. Again, the IVUS images in this particular case are not shown and demonstrated here. So the question is that, we have done a lot of work. We've opened it up, and the CTO had failed before, and should we proceed with the LAD CTO or just call it a day today? Here's the, I misspoke, the IVUS runs for the circ. And again, the areas are mentioned. You can see the first area shown on top panel is 6.91 millimeter square, fairly good. And the distal one is slightly smaller. The stent is expanded, but it is expanded there. So I think, again, not relying on purely angiographic images and taking the time to optimize your PCI result using intravascular ultrasound is another additional benefit when you're assured that these patients are fairly stable with hemodynamic assistance, as in this case.
And another question that came up is, how are the kidneys? What is the creatinine? Creatinine actually was normal in this patient, surprisingly, in spite of all that. I think it was around 1.2. But you're right, and the question comes up quite often, if you want to optimize PCI, can you do OCT versus intravascular ultrasound? I think when you have high-risk cases where you want to minimize the amount of contrast or multi-vessel, three-vessel PCI, then you want to use either IVUS, which you don't have to give contrast, or if you do OCT for some of them, then I think it's best to use dextran rather than giving contrast.
In this case, Manas, if you notice in the angiogram, there is actually some residual question I think we face, is that was there even an intermediate left main disease? I think the IVUS of the circumflex had dual purpose, not only to optimize the circumflex result, but also interrogate very carefully the left main. I think for more proximal and left main interrogations, I think OCT might be less useful and giving a high-pressure injection with the guide engaged in the ostium. I think those are the reasons why, as you can see, the left main and the bifurcation of the left main are very well visualized in this IVUS run on the right side.
Exactly. And I think another question that came in is that, if the LAD that's next fails, then you could try to do single vessel Lima, and that's obviously a great option when available. But again, and it's always a judgment issue. Do you proceed to the complete revascularization now, or do you stage the patient and have them come back even before they go home, or maybe at a later date to open the LAD, which we think is a CTO anyway? And I think, I don't know what you think, but probably depends on your kidney function, contrast you've given, hemodynamic stability, all this factors.
I think once, as you indicated, hopefully I'll show those data later, that and also the chat messages from our colleagues are showing in that I completely agree that if the patient is doing hemodynamically stable, you have a support device in, it might be worth going in for complete revascularization. I think that's is supported at least by some data available from both PROTECT2 and other registry and and meta-analysis currently available.
And there's also a question about doing a right heart cath at the same time or measuring LVDP and then saying, well, if you have a high LVDP, would you give diuretic or not? And I'll just give my thoughts and then I'll let you, Subhash, think. But I think in my mind, that's the nice thing about having the Impella, is that actually it directly unloads the left ventricle. So we don't routinely monitor it. I mean, yes, in very complex cases that might be an option, but the reality is you do have a good LV unloading, and that rarely becomes of an issue. And the question in my mind is more whether do you leave the Impella in after the procedure to make sure the patient is completely stable versus taking it out. And I think if the patient is very stable, and then LVDP might be helpful to decide to leave it or not. But otherwise, we don't routinely monitor LVDP when we use Impella hemodynamic support.
I think that's an excellent point. That's an excellent point. Again, coming back to the case, the stent was post-dilated. A secondary stent was placed more distally, and here is the complete final angiogram as I showed you the IVUS runs of the circ and the left main earlier. So the question, again, I think we have kind of covered this, is to proceed with the LAD. I think most of us who are on the chat and those who are chiming in their responses do agree that proceeding with the LAD is probably the best way to do, and there is some data that we mentioned earlier. Number one, that if you leave patients with a higher residual syntax score, i.e. unrevascularized territory, those patients not only do worse short-term but also have long-term consequences that are not as good as those who are fully revascularized and have a lower residual syntax score, as indicated in this study in JACC 2012, indicated on the yellow line on the graphics onto the left for death and also for non-fatal myocardial infarction in panel B and C. This is a meta-analysis performed by our group, again looking at complete versus incomplete revascularization in terms of mortality with CABG and PCI. Again, of course, this is a meta-analysis. However, it shows that the completeness of revascularization probably is a very, very important factor, and the benefits are equivalent if complete revascularizations are achieved with both coronary bypass and PCI.
Actually, if I can say, actually, this is from Santiago Garcia. This is from University of Minnesota. Santiago Garcia did it, and that was actually the largest meta-analysis of its kind. JACC published a couple of years ago. And I guess in my mind, the main message here is that yes, both bypass is what is done quite often, especially for diabetics, based on freedom. But as you can see here, maybe the biggest thing is to achieve complete revascularization. As long as you can get complete, either with PCI or bypass, at least as far as mortality, you do get similar benefit with 0.70 and 0.72 relative risks.
I think that's a great point. Again, the barriers to complete revascularizations often, at least from the PCI side, are, as in this case, a more chronic lesion, bifurcation, small vessel disease, and I think some of the strategies we'll go over as we proceed to the case. So here is the case. You're trying to now cross the LAD. You have multiple options: antegrade wire escalation, antegrade dissection, or just come retrograde. I think given the characteristics of this lesion, we generally use an objective way of deciding, which is use a JCTO score. And the JCTO score in this case, it does suggest that this would be either a 1 or a 2. The lesion length is approximately 20 millimeters. There is a nice tapered tip. There is not much calcification. And I think that this would be a good strategy in this case to use an antegrade wire with a support catheter.
And if I can say, this is a CTO essentially, and for CTOs we typically do a two-guide catheter in almost everyone. However, this is one of the rare exceptions in which you actually do not have a good collaterals from the other vessel. The collaterals are coming from the same vessel. So I think for cases like this, it is the rare exception to the rule, 1 in 5 cases where you don't need a dual injection. You can do your CTO just with your standard single injection from the guide catheter.
However, careful attention should be paid to how this is crossed, because jeopardizing this crossing and dissecting this artery could be significant and escalate the case. So here is a very simple scheme, and we won't go through the entire scheme, but I think it shows that an antegrade approach with lesions lengths with a shorter probably is the way to go. And I think that if that definitely is not the way, the lesions are more complex, there's an ambiguous proximal cap or poor distal target, it feels retrograde from the contralateral side. I think a retrograde approach probably is the best way. And I think an antegrade wiring and dissection re-entry both should be available and well tested in the cath lab by the operator, should be competent enough to adopt and switch from one strategy to another in between the cases. So here is our approach. As you can see on the screen, this is a Corsair support catheter. You can see that radiopaque tip, and we have a workhorse wire at least to get us into the lesion and not poke into the circ with a more heavy wire. And we also have a second wire placed in the circumflex in this case.
So if I can say, Subhas, in my mind, the most common reason people have a hard time with CTO sometimes is that they don't use over-the-wire system. And that's one of those things, like dual injection is one big thing. The second big thing is to use essentially always a microcatheter. And you want a microcatheter because it gives you better support, because you can change your wire if something doesn't look great, and it just increases your success, likelihood of success much more. And if you remember, in the initial attempt done outside, a single wire was used without the support of the microcatheter. that might have been the reason why they had a hard time recanalizing the occlusion.
I agree completely, and I think this strategy is shown here, and with the Corsair support right at the proximal cap, and changing the work wire with the Fielder XT, we were able to penetrate through the tip, and we'll a separate session to talk about the ways we would shape the tip of the guide wire. The Corsair and the crossing was done with a Pilot 200 subsequently, because the Fielder XT did not cross the distal cap. And after the Pilot 200 is placed in the distal vessel, I think there's one word of caution, is that not to claim success, throw up your arms and say we are done, and take rigorous steps to confirm that this is distally truly in the distal true vessel. And I think the first thing to do in this case is to take an orthogonal view. There are multiple things you can do. You can keep injecting antegrade. I think that may not be the best option. If you're on a dissection plane, you can extend the dissection plane. You can switch it over a balloon and inject contrast. We highly not recommend that also, because sometimes you can be fooled with the vessel, with the wire being very close to the true lumen but not in the true lumen, and you will create a big dissection stain, which will make subsequent treatment of the CTO quite untenable. IVUS is a good idea. However, putting a large caliber IVUS catheter into a 7-intimal plane and diagnosing you are not in the true lumen is also not the best. So the least invasive and the most safest way to confirm this, at least, is to first consider an orthogonal view. As in this case, you can see the wire was it looked very much in the true lumen. So I think an IVUS may have been okay, but I think taking the orthogonal view is probably the best next step to confirm. As you can see in the orthogonal view, the wire is truly placed in the distal LAD, and I think this would be a good time to, if you want to confirm the distal vessel, the wire placement with an intravascular ultrasound, or initially pre-dilate and then do IVUS. So either of those strategies are good.
Okay, so this is the third thing. So you want dual injection is a big thing. This microcatheter is the second big thing. The third big thing for CTO in my mind, the basics, which are the most important things, is never advance a balloon or microcatheter unless you know where you are. Great. That's where disasters happen. You just don't know where your wire is, but you push a balloon. So a small wire perf that has no consequence whatsoever, now you push the balloon or microcatheter, and now you convert it to a big open perforation, creating a lot of issues. So you never advance anything unless you are 100% sure your wire is where you want it to be.
Absolutely, and taking an orthogonal view is probably the simplest way to do it. Here it is. We were able to confirm it pre-dilated with a undersized balloon. As you can see, the wire is truly in the true lumen, and then the next step is to stent it. We used DES 27523. And after, again, with the DES placement, the next best thing, as we have already done in many of these lesions before, is to perform an intravascular ultrasound. I think OCT will be perfectly fine in this situation. But I do think that because the IVUS was already on the table, I think we continued to use intravascular ultrasound in this case. And as you can see, the area is shown in the first panel onto the left of the screen. On the left of your screen is 5.49 millimeter squares, 3.89 more distally, again indicating that angiography we may not be optimal alone, and adjunctive IVUS imaging in a patient who is relatively stable and handling the procedure very well with hemodynamic support gives us the luxury to interrogate with IVUS and make optimal changes to our strategy, in this case using post-dilation. Just want to go back. The whole case was finished in about 24.3 minutes of fluoro, AK 2.2 grays. In contrast, used approximately 300 milliliters. With the patient with normal kidneys, we didn't anticipate this to be a huge barrier. The patient, we left the Impella in, given the fact in this particular case, because the patient had required intra-aortic balloon pump and required pressors in the outside hospital, just underwent a complex PCI. And we removed the Impella the following day. The patient did have a tiny nosocomial pneumonia during the hospital stay and was dismissed in about 2 weeks later, recovering from the nosocomial pneumonia, and currently is doing well and was able to undergo cardiac rehab. So this is a reasonable demonstration of how having a hemodynamic support device would help help the operator plan the case, contemplate using the hemodynamic support device a priori, and not try to use it as a bailout option, and then use it for not only meticulous planning of the case, but perform more complete revascularization, and also using additional adjunctive imaging techniques, and take the time to perform more meticulous and complete optimization of the PCI result.
And actually, there's a couple of questions that came through. So the first question is, about his heart class and EF down the line. So he was class 1 actually. A few months later, his EF was 50%, so increased all the way from, I think it was about 20% to start with, and went all the way up to 50%. So he did have quite a good result. And another question that came is about sizing the proximal LAD and whether we should rely on the conventional wisdom that all men have an LAD that's at least 3 millimeters proximally. And that's an excellent point.
Excellent point. Excellent point.
But I can tell you that the challenge with doing this CTOs or any diffuse disease vessel is that you have to size to some degree to the distal vessel, because you overdo it distally, you get dissect and have to stand all the way down.
And a second point is that that is absolutely right. This point is very good. However, you can always dilate 2.75 to 3.0. The second thing is that if you land a large caliber stent and extend the edge dissection, you have a impact price to pay in terms of future feasibility of coronary bypass surgery. So it is not only just this case, but other situations where I think the wisdom is absolutely, I completely agree. There is no, men should have 3.0 LADs, and otherwise, there is some things to consider. However, I think a 2.75 or 3.0 is close enough, and a 2.75 can be post-dilated to 3.0 or even extended if required. I think that's the logic for this, but I completely agree with the comments made so far. So any other comments regarding completeness and the strategy used in this case, the how use of a Impella hemodynamic support device helps in deciding on the revascularization strategies?
And in the meantime, please write your questions so that we'll be answering them one by one. There's a question about device removal, since they say it's an impediment to many operators, and you're right. So I don't know, Subhash, you want to talk about that?
I think I told you in the start of the case that the step of that Manas mentioned of taking a femoral angiogram and planning for an Impella, and there are some cases that you will not be able to place an Impella. However, I think planning for it and doing pre-closure with proglides, this is our strategy, 2 proglides, has dramatically simplified the whole process of removal. And I think that the other strategy we use sometimes where we have more difficult deployments is to have a contralateral access, remove the sheath from the guide catheter from the right side in this case, and place an undersized balloon in the distal aorta. And if you inflate that undersized balloon and pull it down, it tends to tamponade or close off the ostium of the both left and right iliacs, and that gives you some time to deploy the proglide sutures very well. And may also assist in some cases with manual compression if the sutures don't deploy very well. So those are some tricks that I can suggest, starting with good angiography, pre-closure, and distal aortic balloon that would help you deal with the closure of the arteriotomy.
But there's a good point made that yes, in this particular case, since we, even if you would try to pre-close and plan to remove the device, if we leave it in the device because of whatever reason, then I agree, we take the sutures out. We don't want to leave the perclosures in overnight.
That's right.
And then what you're left with is holding half an hour to 40 minutes of pressure the following day once the device is removed.
With heparin stopped a couple hours before. So I agree with you. The ideal thing is to remove them before the patient leaves the catheter, but if not, again, there are options that can be used to deal with this, but essentially it's a prolonged hold on the femoral artery. I think this brings another additional question that using Impella as a hemodynamic support device requires both a nursing ICU team and a cath lab team well trained and adept. And I think that the courses and the educational sessions we have at Dallas and during Dallas CVI and also at our institutions makes that point is to bring in your staff along with you so that they are well trained both in the cath lab and outside to deal with the device, management of the device, and also with the closure of the device.
Sure. And there was a question about the team at the table. So the second operator. So yes, the first operator. So we had a fellow this was done by an attending and a fellow. So and the AK 2.2 grade, that's not too bad. Now in this particular case, the attending was obviously in the front, but in many other cases the fellow becomes the front. But in terms of radiation, as you noticed, we try to minimize it as much, and we're paranoid here that for any case, including CTO but non-CTO2, you want to minimize the radiation. So we're very careful in terms of how much you use fluoro. We use a lot of fluorostor, so we don't have these extra cinerans. Balloon inflations are documented with fluoro, not with cine, the fluorostor. And then we're very careful not to over-radiate the patient. But again, you're right, for complex cases, CTO, multivessel disease, whatever, it's always very important to be very careful and minimize the amount of time that one spends on that.
Fantastic. So Manas, coming back to the hemodynamic support device, so again, let's answer this question first.
So another question is about from an SVS paper that says that the major vascular complication rate was close to 20%. What is our experience with major vascular complications?
I think that both in terms of device success and also complication, there is a very good, simple learning curve. I do think that this 20% is certainly not is observed in our experience. It is definitely in single digits. I wouldn't say that there are no complications. However, these complications can be very well managed with careful planning and adherence to some of the 3 steps we mentioned earlier in the presentation.
And I think here in our institution, I think what helped us a lot is doing TAVR. Having to do TAVR and dealing with the initial 24, now 16, 18 seats, I mean, that really helps you plan for this large access and becomes much less intimidating. And, using the pre-close technique, having 2 pre-closes with 9 and 11 or 1 o'clock, that really helped us.
And the balloon tamponade. I think the balloon tamponade in our case has definitely helped us, and I think that really helps you gain control. Because once you have a hematoma, even the pre-closure becomes a problem, and also manual compression, of course, becomes a huge problem. So having the site and the access site dry and without a hematoma, with the contralateral balloon occlusion of the distal aorta, certainly would facilitate a much lower complication rate than the 20% quoted in some of the publications that I'm also aware of.
Absolutely, and I think as you said, it's very nice to do this, to do the pre-close, and then inflate the balloon, and then you're doing your final closure, and the field is dry. You don't have all the blood coming out, you don't have a little pool of blood, everything is nice and dry. And
let me use just 1 minute to promote, for a promotion, that,
we're talking about the aorta. The question is,
yes,
usually we put the balloon in the aorta, not the common iliac, because then you have to go and wire the common iliac, too much trouble. You just put a 20 balloon or 22 balloon on the distal aorta, and that does the work.
Yeah, and it should be low pressure, so it should sag and pull it down. It sags into both the common iliac osteas, and that's the strategy. Having said that, we would really invite each one of you to consider coming to Dallas and attend one of our Dallas Research Corporation organized Impella and hemodynamic support training courses and hands-on experiences and case reviews. We also have a symposium every year. This is the 5th year. It's called Dallas Cardiovascular Innovations. It is held in Dallas, and this year it is planned in January 15th and 16th in Dallas. And the website, if you would like to register, is www.dallascvi.com. And I couldn't resist not saying this and promoting our expertise and be available for any questions and future comments. And if you have any cases you want to share with Dr. Balakis and myself, we'll be happy to do so. Our emails would be published, and I think please feel free to reach us out through this invite we have sent you and otherwise, and we look forward to someday seeing you in Dallas. Thank you very much.
Yeah, thank you, Subhash, and again, thank you all for attending today. I think the goal of this webcast is to get you more familiar with hemodynamic support, but also we can do now complex cases that we couldn't do before. I would like to thank Abiomed for sponsoring this webcast and for their support.
And Dallas VA Research Corporation for organizing this event, and thank you all for joining in and taking the time out of your practice for being with us today.
Thank you so much, and have a great day.